Welcome to the Ashby Village Science and Ideas Group. I'm Joe Ebinger, and I coordinate this group's events with the help of our co-host and tech expert, Hilary Naylor, and Sarah Ebinger, who will soon introduce today's presenter. All of our members in this group have varied educational and work experience backgrounds, but we all share a common interest in science and ideas. We currently have over 70 members in our group and another 100 on our guest list. We meet via Zoom the second Thursday of most months from 3 p.m. until about 4:30. We have a different guest speaker each month who speaks on a topic related to science and ideas. Next month, Jim Gasparini, a historian, will speak to us about fire. At this time, he's planning a talk titled, "What is Fire? The Complex History of an Elementary Question." Next month, John Schwartzberg, Dr. John Schwartzberg, will speak to us in October about evolving CDC vaccination guidelines, a rise in measles cases, and renewed discussion of vaccines for diseases such as Lyme disease. Sometime next year, we hope to have a biostatistician speak to us. She is currently doing dementia-related research. We rely on our members to find us speakers. If any of you personally know someone who might present to us, please introduce them to me via an email. And please, Hillary, put my email address there. Special thanks to Hillary also for hooking us up with today's speaker. We invite all Ashby Village members to join our group. Others interested in Ashby Village and our presentations are also welcome. All are welcome. Ashby Village is a 501c3 tax-exempt organization, and we do ask that you can, if you're a guest, please consider making a donation to Ashby Village or even joining our organization via our website. Sarah Ebinger will now introduce today's speaker, Jane Neilson. Sarah?
Jane, whom we are very glad to have as an Ashby Village member and a speaker today, was awarded a stipend from the East Bay chapter of the HLAA, she'll tell you more about them, to attend its 2025 National Convention and report back. The Research Symposium on Stigma was her favorite session since it explained her own experience. Born with mild to profound bilateral sensory neural hearing loss, as was her mother, older sister, and brother, Jane did not get her first hearing aids until the age of 30. Those aids relied on analog technology, creating the Bluetooth and digital advances today. With a BA in journalism, Jane built a career in public relations and marketing. Her last position was with a construction management company. She earned her 15 minutes of fame as advanced woman for the backhoe when she was public information officer on the car system rehab project. After leaving the work world, she earned an MA in arts and consciousness. She spends her free time with art, travel, and Osher Long Learning Institute courses. As an Ashby Village member, she has been researching possible acoustic improvements for our meeting space. Take it away, Jane.
Okay. All right. Thank you. Glad to be with you today. I attended this convention that's showing on the screen as a delegate from my chapter, local chapter. And the reason this symposium was so special to me was it explained my own behavior. I was born with hearing loss. I first became aware of it as a child playing Pass the Secret to other children. And that means you whisper something into someone else's ear and it's passed along. Well, I always got the whispers wrong because I couldn't hear them. And that's when I learned there was stigma associated with not being able to hear. And the reason I didn't get a hearing aid until 30 was that there wasn't much attention paid to hearing loss. I was considered more moderate compared to doctors dealing with deaf children mainly. So I followed in my sister's footsteps when she first got a hearing aid and then got me on to getting it. And I actually had to convince the doctor to give me one. So I'm going to share what I learned at this convention, not as a scientist or a medical person, but as from my background of journalism. But first, I want to take a pathway to show you how hearing works. So this is a model of your ear, and the sounds come in from the outer ear. This is the external ear. You can see the outline there. So sound waves enter this channel. They hit the eardrum and vibrate. And then they go into this chamber where the three tiniest bones in your body are located, appropriately called the anvil, the hammer, the anvil, and the stirrup. Those bones amplify the sound, and the sound enters this snail-like chamber, the cochlea. And this chamber is filled with tiny hairs. I'll show you another picture of that in a moment. That a fluid-filled chamber, and those hairs bend with the sound. And that helps transmit that sound into the auditory chamber and into Grand Central Station, your brain, where the brain processes that sound and lets you know if it's music, noise, or speech. And by the way, the same chamber is also the center of your vestibulary system, which is your center for balance. And the most recent finding is that if you don't treat hearing loss, it's a risk factor for falls. So it's kind of like a Rube Goldberg machine, if you've ever seen one of them. He was a cartoonist and a sculptor that made these contraptions where one thing set off motion on another and another. So you may ask, well, what could go wrong? Well, let's see. Here. The main causes of hearing loss are age-related, noise exposure, genetics, ear infections, ototoxic medications like chemotherapy, depending on where it's administered, can lessen your hearing, trauma to the head, chronic conditions such as diabetes or issues that affect the blood flow to the ear. And generally, all of these different reasons fall into two categories. One is conductive, and that's external ear, middle ear. And the other one is nerve loss, neurosensorial. And this is where 90 to 95% of the hearing loss occurs. The other ones, the external ones, is called conductive. And that's about 5 to 15% of the cases. So, risk factor, age is a risk factor for hearing loss. About 50% of the people over 60 have hearing loss. 65% of people 71 and older have hearing loss. And 80% of individuals 80 years older have hearing loss. And the loss in this group is mostly due to the wear and tear on these hearing cells. So here's a close-up of your cochlea. Remember that the tiniest bones in your body amplify the sound, and it enters this chamber, and this chamber is liquid filled, and it has tiny hairs that bend. And here's a illustration of how that works. And those bend and fold with the sound, and it creates signals that then go into the brain. So unfortunately, those cells deteriorate as we age, and they do not regenerate. And they also deteriorate in a tonotopical fashion. And you think of a piano, the high keys are located in one location, the low in the others. Same with us, the way we hear frequencies. And the high frequencies are the ones that go first. And unfortunately, those are the ones that carry meaning in speech. It's high-pitched consonants such as S or F or TH become hard to hear. And that's why you may have had the experience of hearing words, but not knowing what someone is saying, because you didn't catch all of it. You didn't catch the sounds that are the hardest to hear. So that's the bad news. But the good news is that hearing aids and hearing devices can help, and that this is the best time in world history to have hearing loss, because we have so many advances that weren't available before. So back to what I learned at the convention. The research question that was studied was this: that many people with hearing loss wait 7 years or longer to seek treatment or never seek treatment at all. And the question they wanted to address was, what role does stigma play? And is the public's perception of hearing loss improving over time? So I told you my experience with hearing loss. I learned about stigma as a child playing Pass the Secret. And I didn't get my first hearing aid until the age of 30, and I was thrilled because it made such a revolutionary difference in my life. Just imagine having a mild to profound hearing loss and trying to go through academic school, starting a job, and so forth. So I was really thrilled. However, I can remember a time when my clinic called my place of office and left a message, because I wasn't there, that my hearing aids were ready for pickup. So I was mortified that that became public knowledge. And keeping my hearing loss secret was my strategy for the next several years. And I suspect, well, many in the science and ideas group, you're probably of the age where you're newly affected by hearing loss. So if that's true, you've lived long enough to develop an identity and a strong ego. But stigma may affect you just as much. I find first-time hearing aid users that are now my age are reluctant to spend money. They try to do it on the cheap because hearing aids are expensive. and they get frustrated with the big learning curve to suddenly having hearing aids in your ears, and they do things like don't wear them every day, or they don't wear them if they don't see people, and that's not good for helping your hearing. So this convention, there was a group, a fabulous panelist group that covered these topics, and I'm going to relate the findings of three of them. So Dr. Laura Nyblade covered what is stigma itself. Dr. Jessica West covered what is hearing loss stigma. And Margaret Walhagen covered hearing in the healthcare context. So starting with Laura Nyblade, she was not an expert in hearing. She was an expert in the science of stigma itself. She studied stigma as it related to AIDS and HIV for 2 decades and in 2 different countries. And she was recruited to co-chair a hearing loss research team to apply lessons that she learned from the study of HIV to hearing care and help devise criteria and ways to measure stigma and implement change. Because in the medical world and in the science world, you have to, if you're going to make a case, you have to measure the problem, produce evidence before you can produce remedies. Okay, so what is stigma? What she said is that stigma is something we do for each other. It's a social process. So it occurs within the context of power. We as human beings distinguish and label differences. We associate negative attitudes to those differences. For example, you might distinguish and say, that's an old person. That's a person who uses substances. That's a person with hearing difficulties. You may associate negative attributes such as, oh, that person is a burden or incapable or frail or slow. And you separate us from them. Like, we're fine. We don't want to have anything to do with those others. And that creates status loss and discrimination. And a friend of mine who's a grandmother told me about her grandson who has autism. And he is in special ed classes. And the other kids call him SPED, like for special ed. So discrimination is all around us. And we do it ourselves. We're just not in tune to what we do to each other. And then as far as hearing loss stigma, how does it differ? So hearing loss stigma is the negative or unfair beliefs about hearing loss or hearing devices that make people view it as abnormal and undesirable, something to be avoided. And how does someone with hearing loss experience stigma? Well, in the case of Dr. West, who presented this section, she studies how hearing loss affects people's health and well-being throughout their lives. And in her case, she has a severe, moderately severe hearing loss. And she got her first hearing aids at the age of 17. And it took her, she went in the business later, but it took her 17 years to admit that to anyone else. And the many ways that stigma can be felt, hearing loss stigma, it can be anticipated. You may have a fear of stigma, whether or not it's actually experienced. Like you're afraid if you wear your hearing aid, you'll be viewed as unattractive or older than you are or weak. It can be internalized. The stigma might be self-directed, like you feel embarrassed or ashamed or insecure, an outsider. For example, I feel this quite often, feeling left out or humiliated when you can't hear laughter, what everyone else is laughing about. Everyone else is laughing, you didn't get the punchline. It can be perceived. You may witness stigmatizing attitudes in the community or among groups. So if you see someone else with hearing loss being viewed as less intelligent or less capable or unfriendly or rude, you may be fear being judged that way yourself or treated with impatience. For example, Dr. West, who presented this segment, reported her fear of being perceived as less intelligent because she had to ask for questions to be repeated when she gave presentations during the Q&A period. And then, of course, you may have had real life experiences of stigmatizing behavior. So how often have you been shown less respect or excluded from activities, teased or made fun of? Or how often does someone become frustrated with you? For example, just being told when you ask someone to repeat something, never mind, because they're too impatient to repeat it. So you may ask, so what? Why? Why do these slights matter? Didn't we all grow up learning the retort, sticks and stones may break my bones, but words will never hurt me? Why is stigma being studied in relation to healthcare? Well, the reason is because it influences behavior. We are the most social of the species. And stigma can affect whether or not someone perceives the need for care, desires care, and actively searches for services. And also whether someone has access to appropriate and thorough health assessments is included in healthcare decision-making or experiences inappropriate assumptions about their cognitive status. So providing a perspective on hearing in the healthcare context was Meg Walhagen. And she's a local hero, in my opinion. She's a faculty member at UCSF and a gerontological nurse practitioner. And she has studied hearing loss and its impacts on families for decades. And for simplicity's sake, I'm going to call her Meg since we shared a Uber ride to the convention. So what she notes is that the healthcare network has a lot of players. you not only have the person with hearing loss, you have that person's partner or family, you have the provider, you have the health system itself, and you have a societal context. And what she pointed out is that hearing loss is poorly understood by providers, and that stigma impacts healthcare directly. What she noted is that despite multiple efforts in new technologies, efforts to get broad, sustainable approaches to promoting communication access in the healthcare setting have not been successful. In other words, there hasn't been a cohesive effort to see the importance and do something about it. Well, being a gerontological nurse practitioner, Meg's interacts with a lot of palliative care providers. And she noted that they go to a lot of trainings on good communication skills. So she would ask them, do you train about hearing loss? And the answer was no. Do you ask about hearing loss? And the answer was no. So she devised a survey. She and her cohorts devised a survey of 510 palliative care providers. 91% of them reported that hearing loss had some or great impact on the quality of care provided. 88% reported a communication problem with the patient, and 56% reported a communication problem with the caregiver. This survey had quotes on it, and I'm going to share some of those quotes with you because they really help illustrate the issue. So the problem with not having good communication between someone with hearing loss is that symptom assessment can end up being limited or not completed. So this doctor, or the person answered this, said, it's difficult to assess symptoms accurately when the patient has hearing loss. And there's a second quote that bothered her even more. It was someone saying, I tend to not do a full assessment when confronted with problems in communication. And she noted, well, palliative care is all about talking to individuals about their goals and to do symptom management. And if you don't get at the symptoms, you don't manage them well. Another issue that came up was misinterpretation of cognitive status. A patient can be assumed disoriented if not answering the questions correctly. And mistakes, like prior to the erasable communication board, everyone on the team thought that this patient was demented. He wasn't. And a third one that she mentioned, an elderly man whom people assumed had dementia did not, and he felt very humiliated. Another issue that comes up if the hearing issue is not addressed is the patient gets left out of the goals of care. So self-determination and decision-making can be more difficult. They may defer to their family as they can't hear the options presented. or that the caregiver speaks on the patient's behalf, despite efforts to communicate directly with the patient. And an additional quote, the patient was not able to participate in decision making. They thought he was confused and compliant. And that wasn't true. He couldn't hear. And another part of her surveys took up the patient perspective. She wanted to find out how many people are asked about hearing during primary care. And this person, the longer quote is, not that I recall, because I never came in for any issues with my hearing, and I didn't get my hearing aid from this health system. I'm thinking of my present person, probably way back when, 10 years ago, before I got a hearing aid. I'm sure we discussed it because somebody obviously at the clinic referred me to the hearing department. But that actually, because I initiated it, because I could tell I needed an aid for work. So I have to say no. And I'm not bashful about saying, could you please repeat that? In other words, to me, this person gave clues that he couldn't hear because he would ask for repetition. The doctor should pick up on that and ask about the hearing. I know an example from my going to the Hearing Loss Association chapter in the East Bay. I heard a member say that her doctor never asked her about her hearing, and she was losing it gradually and not realizing it. And then there's been a problem with people who do have hearing loss and need some medical work where the communication of that is not picked up on the other end. This is a person who says, unfortunately, he's been to the ER a few times because he has heart problems. And usually his wife is able to go with him and be his eyes and ears. But in this case, there was him, and he would tell them, I'm deaf in the right ear. And there was not a lot of attention paid to it. So the point being that even when told about a hearing issue, that a person may not always get the right attention. Another issue that came up was missing information without knowing. So, do you routinely tell them you have difficulty hearing? I do now because I need to know what points they are trying to make. So, yeah, it is past the point where, just tolerating it or letting it slip by. So, follow-up was, do you always ask for clarification? Yes, if I couldn't hear, I did, yes. But I felt funny about it. You hate to say, what did you say? But I did because I needed to know. So this person was asked a follow-up question. Why did you feel sorry or bad about saying you needed to have them clarify what they were saying? Because I guess I didn't want people to think I couldn't hear. It's like there's something the matter with you. What's wrong? You can't hear? So patients realize the need for self-advocacy, but they also experience exhaustion because of it. And Meg cited a survey that was done in the UK, where the author of that survey asked about people's comfort talking about their hearing issues. And fit in three categories. One, those that were open, happy to talk about it. Those that were anxious, not really wanting to talk about it. And believe it or not, those that are unaware, they do not know that they are deaf or hard of hearing. And she said it raises questions in the healthcare setting when you have to know the information. So the burden of advocacy can be significant. It can lead to burnout. For instance, this person that I can begin to feel anxious again about telling people I am deaf or asking someone to communicate with me in a different way. I end up forgetting parts of my usual script, leading to further mop-up conversations in the future. And that hearing people need to be reminded they start out well, but they soon forget I need to see their lips. They speak clearly for the first few sentences and then taper off into a mumble. It's a perpetual internal battle between, am I making too big a deal of this? And I deserve access. So the point is, we're putting a big burden on individuals who come into the healthcare field, especially when they're coming for something that's stressful and they may not be able to get their story out. And self-advocacy should be shared between the provider and the patient. So there's an institutional awareness gap, and the failure to be inclusive regarding hearing loss means that healthcare providers, the administrators, and policymakers tend to ignore it. And it's not that these individuals don't care. Rather, they are unaware of the magnitude of the issue and the potential implications. So what is missing from this picture? What's lacking? And a reason for the symposium on this subject is research, measurement, remedies, and integration. And this kind of research symposium is a way to push changing that. So as far as the magnitude, hearing loss is the third most common chronic health condition. It's twice as prevalent as diabetes or cancer. So why isn't it given more attention? Well, one suggested answer was because it's not fatal and it's largely invisible. And I have a book to recommend to you by a local Berkeley author. She spoke at Ashby Village once. Her name is Claudia Marseille, and she wrote a book about her own experience, and it was called You Look So Normal, Lost and Found in a Hearing World. And that title, she had severe hearing loss due to her mother taking painkillers during her pregnancy where they didn't know that yet that this was a side effect that it could affect someone's hearing. So hearing loss by the numbers. It involves 50 million Americans, 50% of people over 60, 1 in 5 teens. And surprise to me, which I found really devastating, it's the most common military service related disability among veterans. Meanwhile, only 1 in 5 people who would benefit from a hearing aid actually uses one. Discussing this wasn't part of the convention, but I read some articles about what the factors are about this decision. Well, one involves cost. Another was perceived lack of benefits. Maybe a person tries one and doesn't like it and gives up. Denial of hearing loss. Oh, I'm fine. But the most difficult disincentive to overcome turned out to be perceived stigma about hearing associated with hearing loss and the use of hearing aids. So back to the hearing in the healthcare context. We heard there's multiple players. There are also system constraints and competing demands. So the healthcare system has to deal with multiple problems, trainings, assessments. It also has to deal with what they call never events, things that should never happen in a hospital, such as things like falls at a hospital or infections within a hospital or doing the wrong surgery. So a lot of time gets focused on those because of financial penalties. And meanwhile, our primary care providers, are asked to do all kinds of screenings from depression to falls to social determinants, but not hearing. As one patient put it to Meg, they ask me if I'm safe at home. They don't ask me if I can hear at home. So we ask about all these other things, but not about hearing because of time pressures. So she purports that it needs to become built into the routine, built into part of the system, just like when you go in, you get your weight checked, your pulse checked, etc. But that we also need to identify strategies for change because this is an optimal time to make hearing loss screening routine. And she pointed to a way forward that's brought about through a trend called age-friendly health systems. It was an initiative by the John A. Hartford Foundation and other groups within healthcare field and some hospital associations to improve the health of older adults. It's based on what they call the 4M system. It starts out with what a person's goals for care and personal values are. What do they want to keep going and doing? What do they not want to lose? And hearing is essential to finding this out. Medication. You want medications that are age-friendly, that don't interfere with what matters. And hearing is necessary to understand the regimen. You want care that helps your mentation, your mind. And hearing loss affects cognition, and it's a risk factor for dementia, depression, and delirium. It's also more recently, we've learned that a risk factor for falls because the vestibular system and the cochlear system share the same channels into the brain. And there has been clinical evidence that there is a correlation between having mild or moderate hearing loss and an increase in risk of falls. And she thinks that we'll also get some more momentum because Medicare has introduced a new initiative in 2025 called the Hospital Inpatient Quality Reporting Program. And it's a program where they will pay to hospitals benefits if they can report that they have introduced age-friendly protocols. And those protocols relate to the 4 M's really about asking a person's goals for care, responsibly managing meds, implementing frailty screening and intervention, and establishing age-friendly leadership. So what Meg is pushing for, what she's hoping to see become normalized, is a mainstream hearing assessment. It doesn't mean like a full hearing test where you've got the earphones on and an audiologist tests you necessarily, but it means just asking about it, checking on it, just like noticing if a practitioner noticing the patient has trouble understanding and asking and pursuing and looking into that. And if there's something that can be implemented in the normal primary care all along the way, it reduces the burden for self-advocacy because she feels that you're just checking on hearing. It's just part of healthcare. It doesn't mean you're an oddball. So just to recap some of the things I've spoken about. Stigma is a real phenomenon. It's experienced in many forms. It may sound trivial, but it matters to us because we're the most social of the species. It can even affect our health outcomes if we let it. And unaided, untreated hearing loss is a risk factor for many things. For falls, depression, delirium, and cognitive decline. And to take care of our hearing is to take care of ourselves. And I'm going to open it up to questions now. I want to point to this website here. This is the Hearing Loss Association of America website, and it has fabulous facts and feature articles on living with hearing loss. And they've been a big supporter of getting things legislatively introduced, such as testing infants for hearing loss, having anybody who sells hearing aids also talk to the customers about T-coil, telecoil advantages, and so forth. So if you want to know more, I recommend that you look at this. They have very interesting articles. And you'll know that if you have hearing loss, you're not alone and that there's things you can actually do about it. So, okay, so that's my slideshow. Some of you are interested.
Yeah, I put the link in the chat for people. And the book recommendation is there too, if you guys want to save the chat. No questions in the chat so far. Oh, well, I had one. Would you send your slideshow to the Science and Ideas group, or send it to me to send to the group?
Sure.
I think you got it in a PDF format or something like that.
Right.
Yeah, that'd be great. And then the YouTube will be posted in 2 or 3 days, so we would have both together.
Okay. Well, anybody have questions about hearing loss or the slideshow or my experience? I have 80 years of experience with hearing loss.
I think Riley has a question. Riley,
Yeah.
do you want to unmute?
Yeah, I do have a question. I've had hearing aids now for about a year, and when I'm asked how they're working for me, I have to be honest and say I think the improvement has been really, really subtle. um, Also, I've read that even the best hearing aids, the highest ticket hearing aids out there are just flat plain not very good when you're dealing in a fairly noisy social setting with a lot of talking going on at the same time. That
Yeah.
they just have not yet, the technology has not advanced to a point where uh, hearing aids can, I guess, differentiate one speaker from another, maybe. But I have heard that AI is starting to be more and more incorporated in that. That there's that the brain part of, not the brain part, but the active part of the hearing aid. I wear the kind behind the ear.
Mm-hmm.
In that, at least in that particular kind of hearing aid, that AI is something that is being used, or they're speculating at least that it will be used more in the future to make them more effective.
Yeah. I have hearing aids as of this year, brand new ones that use quote AI.
Mm-hmm.
And another audiologist told me that, well, live AI is yet to be introduced, but the kind of AI that's used in my hearing aids is that they pro they do a string of spoken words and then with noisy backgrounds and teach the hearing aids to
Mm-hmm.
sort of recognize from that pool.
Right. Right.
Um,
Did they teach it with your voice?
no, with the other people's voices,
other
things you
people-
might hear.
I'm sorry, people that you might hear. It's
You
not.
can't, well, that gets into auditory training, which I use. So the thing about hearing is you hear with two ears and one brain, and you can actually train your brain to pay better attention. And I have an app on my phone. It's called LACE, LACE. It was developed at UCSF. And now it's been launched in commercial, and audiologists sell it through their practice. So I do a training almost every morning, about 15 minutes, of listening to people speaking in background noise. And when the first time I heard it, I couldn't believe it. I thought, how horrible. They're making me listen to things in the very environment that I hate to be in.
Hmm.
But I got better at it. Astonishingly, at first I couldn't hear a word. And I would replay something and begin to hear words. And then as I went on to other topics, I can tell that I've gotten better at it. And I think one of the reasons I got better at it is because I learned to pay attention. better attention, because when you hear that noise and you can't make sense of it, the temptation is just to tune out because it's so stressful. And then to subject myself to that as a learning device has helped me.
Hmm.
The other thing I think is interesting. I think it sounds like you're very sophisticated in your use because you're noticing things. My new hearing aids, they have a microphone in front, they have microphones to the side, and they have microphones to the back, which means that if the sound is coming behind me, say I'm in a classroom and people behind me are talking, I can actually pick up on what they say. Or if somebody is to the side of me at a distance, I can pick up what they say. And at first it was wildly disconcerting because I'm used to having it come in from the front only. Um, but I'm giving myself time. I've gotten, because it takes a while to get used to something new. And I think if for anyone, my advice to anyone with a hearing aid is become a sophisticated user. Notice what you like and what you don't like.
All right.
And talk with your audiologist. I get a new hearing aid thanks to my health plan every 3 years, and there's enough advancement between that time that the new one is worth getting.
Okay. Yeah, I've had mine for about a year.
Mm-hmm.
My set for about a year, and I don't know whether I have I think the brand is Jabra that I have. It's one of the 3 or 4 that was available, and it's apparently considered to be a pretty good brand, apparently.
Mm-hmm.
But I was not aware that the speaker that goes in the ear canal actually can sense sound behind, at least the model that I have. Maybe
Oh,
it does, and I'm not aware of that. I don't know. Mine are actually in the shop right now. I
uh-huh.
detected a problem with one side, and they took them and tested them and said, "Yeah, there's something going on here." So I don't have them right now, but I don't recall. Well, again, I don't know. It's been a very if there has been an improvement, I guess there has been for me at least. It has been a very subtle improvement, and I think part of the reason is that the setting that I kind of was hoping they'd be the biggest help in, which is a setting with a fair number of people talking at the same time. That's kind of where I find myself, a number of times a week. Um,
Yeah.
again, from what I've read, is that frankly, they're still working on that. These, even the top flight hearing aids, just aren't very good at differentiating speaking.
Yeah.
They're just not. The technology isn't there yet. That's what I read.
Yeah.
Yeah.
Well, there's another device you can use to supplement that. It's called the Roger, and it's like a microphone you put on a table that picks up the sound from the other speakers.
Oh, oh, honestly, is that right?
Yeah.
Called
Yeah.
a Roger, R-O,
GER.
oh, Roger. Oh, really? Oh,
Yeah. That's one with a particular brand, I think
okay.
Phonex. But you might ask about what they call accessories.
Yes, I will.
Yeah. And
Okay.
another accessory, I don't have a Roger, but an accessory I bought was listening to the television. So I can get Bluetooth directly into my ears.
Yes, and I have that. In fact, that's how I discovered what I think is a problem with the left side because I was using Bluetooth for streaming and I wasn't getting the left channel. I was getting the right channel, but the left channel would only come through if I stuck my finger in my ear canal. And so I'm walking around, and then I would get it, but as soon as I pulled my finger out, then it would go away. So
Okay.
something was weird there. And that's what kind of got me thinking if the left side is having a problem with the streaming aspect, the the Bluetooth aspect of it, could that also be indicative of the fact that it's having a problem just generally? That maybe it's just
Ah,
up.
yeah.
And I can listening to streaming with just one side is not a big deal. I can hear it and it's okay. But I began to wonder, well, hold it now. Does this also mean that when I'm not using the Bluetooth and I'm just out in a setting somewhere, is it still, is that problem still there? And I just
Mhm.
never noticed it until I started to use the Bluetooth. So
Mhm.
I don't know.
Okay, we have a queue. So William had his hand up first, and then Mark, and then Audrey. So William, go ahead.
I got what I thought would be state-of-the-art Phonak hearing aids about 4 years ago, but I found them just inadequate when I was in a noisy room setting. And I know that feeling of stigma because I would decide not to go to certain things because I was pretty sure I was going to miss parts of a conversation and embarrass myself if I didn't understand what someone was asking me or talking to me. But last summer, I was in Los Angeles and had lunch with a guy with a cochlear implant at an In-N-Out burger. And we were sitting outside at a table, and he had his cell phone sitting on the table face up. And the loudspeaker would announce the numbers of the orders, and suddenly he said, "That's our order." I could not hear what the mic or the loudspeaker had said, but he had an app on his phone called Otter, and Otter converts speech into text, live speech into text. And so he was looking at his phone and he saw the number of our order called and he went in. And I thought, well, that is a super duper app. But when I got back to Portland, I decided to see if I was eligible for a cochlear implant myself because I was having such a bad time hearing. And the two-part assessment, the first one is to have a clear audiogram of what frequencies you're missing and all that. The second one, they put you in a booth with the top of the line hearing aids. And with that situation, I understood 77% of the sentences that they tested, which meant I was not eligible for a cochlear implant, but for better hearing aids. So I now have, the top of the line ones and things are much better. But I want to contact this association because I'm sure they can help me figure out how to get Otter to work on my phone because it's just, I downloaded the app, but it's not working right. Probably because I haven't paid for a subscription. But anyway, I thought Jane had mentioned apps, and
Yeah.
this is another one that's really valuable for hearing impaired people.
Yeah. If you have an iPhone, you can get text on your iPhone. You can punch a button. I do it in lectures sometimes, and it'll write out what's being said that it can hear from a microphone. And that's free. It's part of your Apple phone.
Right.
Okay.
Can you spell Otter, please?
OTTER.
Okay, thank you. Mark, go ahead.
Yes, regarding stigma, I usually, excuse me, I usually attack it head on, and I will go out of my way if the occasion arises to say that I've got these great hearing aids, but and I can do everything. They're almost like they don't exist because they're totally in my ear and they stay in my ear for it could be weeks at a time. And another great thing that I tell people about them is that I can turn them off completely. And it's just like I have hearing muffs on so that if I go to a very loud basketball game or something like that with all these words and things, I can just turn my hearing aids off and enjoy the game. Anyway, that's these things are called lyrics, and they're, like I say, they're totally in the ear. You can keep them in the ear until the batteries wear out, then you put new ones in.
Mhm.
And the nice thing is also you can use things like the little AirPods. Anything that you have normal, you can use with your normal ear, you can use with these hearing aids. But that's just my experience.
Mhm.
Audrey?
Well, I have Phonak hearing aids, and I also have a Roger. And I find that the Roger is really useful when I want to talk with someone or listen to someone who's, for example, not close to me, like ahead of me on a path or at the end of the table or something. What is not so good about it is that it will blank out any other speaker, or at least will reduce the volume so that I can still hear the person that I want to hear, who's got it hanging around their neck, but I can't hear so well the other people who don't have it hanging around their neck. So sometimes I opt for not wearing it or not asking someone to wear it, because I do want to hear other speakers when they come into it. So, the thing about these other apps that you can use to get the speakers' voices written out, I think that's a good idea. And I haven't tried those yet, but I think it's a good idea. That's it for me.
Any other questions before we close it down?
I had a couple comments of feedback to Jane. I don't fortunately yet have any hearing loss, but we also have that low expression cognitive dissonance where people just tune other people out. It's not necessarily hearing loss, but they're just thinking in their little heads. So anyway, you mentioned a couple things that I really loved. You talked about mop-up conversations. And I thought that was a beautiful image of what we do. We haven't quite gotten what's going on, and then you have to have a little mop up to catch back up. And you also talked about people being left out of care goals, and that really hit home. I've cared for several older people, and I think that hearing and age are two things that really put people in that spot of being left out, and a caregiver will take over, or somebody else will just, you are left out. So I thought that was a really great point that you made. And then my other question was to do with the when you talked about the fact that this contributes to falls. You don't hear someone say "watch out," or what are the kind of situations that?
Well, it seems like there's two, and it's a really hard system to understand. I'm not medical, but there's an Ashby Village member, Mary Kawar, who is an occupational therapy, and she's a specialist on the vestibular system.
I will talk to her.
Yeah, no, she goes around the world teaching about it. And they're connected. She really couldn't explain it to me. I couldn't understand it. But the two things I know is, one, is if you have hearing loss, you have to work harder to hear people. And other parts of your brain take over. That's one reason. Like the executive function, it's going into the executive function. You have to strain to hear, or you get exhausted from trying to hear. So it diverts your attention.
Mm,
In other words, you're busy thinking. But the other one is it has something to do with balance. It's in the same channel. The
okay.
vestibular system is made up of the vision and hearing and position, how you know how you're being in position, if you're falling or upright or so forth. And she told me, which I found astonishing, she thought that the hearing was more important than the vision for balance.
And could you say her name again so we can get that in?
Mary Kawar, Kawar.
Thank you.
She's
Thank you.
she's going to give a talk in January at the hearing loss chapter that's East Bay. It meets at Oakland in the Kaiser building.
Maybe we'll get her to speak to us too.
Yeah, what? Yeah.
Thank you
Helene
for
had a
that.
question. Thank you, Sarah. Helene had a question she asked in the chat about her husband who used to wear hearing aids and now doesn't want to. And she can still have a good conversation right next to him, but it may not be so easy in a group. Have I got that right, Helene?
Well,
And
he does hear in a group. That's what's so strange. He has memory loss. It has not been diagnosed completely. But I had to put him in a care home 3 months ago. And he seems very stable now. And you sort of wonder, gee, I should have him back at home now. He's not doesn't seem so difficult. But anyway, he's doing fine. And he decided not to wear his hearing aids anymore. And I had just had them checked out. And then I changed the batteries and do all these things every week. And he just would take them and throw them on the floor. So when we go visit, we have conversations. And then when I show up, he may be participating in a group presentation by a person who comes in to entertain the 6 people who live in the house. And he's right there trying to participate and says things. It's just weird. And forever he would say, I can't hear you. I can't hear you. And it was because he didn't have them on. So I don't know what's going on. But anyway, it's just puzzling.
Huh. Well, I want to show you, we were talking about my phone being able to translate into text what someone's said. So here's a sample. You can see my own voice being translated into text. And it's on your iPhone. It's free. You get it in.
What's the name of the app?
Well, if you have an, let's see. I don't know what the name of it is, but if you look in your, if you have an iPhone and you go through the under general and look for accessories or accessible help, it would be somewhere in there.
Thank you.
I would like to add, we spoke of Mary Kawar. She actually spoke to us and made a presentation on the vestibular system.
Oh,
And you can find that
interesting.
the entire presentation at the Ashby Village website. You simply click when you sign in. You don't have to be a member. When you sign and you go to the website, you click on, there's a big red button in the top right that says something YouTube. And then if you scroll down, you'll see a presentation made August 8th of 2024. And she spoke to us. The talk title was Vestibular Support for Thriving in Gravity-Bound Space. So,
Huh.
I think that's it.
Well, I just want to give one tip to everyone who wears a hearing aid. I've found that a lot of people don't want to wear their hearing aid every day. When they're at home alone, they're not going to see anybody. it's just like taking your glasses off. You like some relief. But I'd encourage you to keep wearing your hearing aids because the brain is still working and it's picking up auditory cues and you're learning from that. So if you don't give it training, it's not going to do as well.
Any other questions before we all applaud Jane for her wonderful presentation? And bravo.
Thank you.
Thank you very much. And hope to see you all next month when we're going to learn more about fire. Thank you.
Thank you.
Okay.
Thank you, Jane.
Okay.